I don't agree with is that a lot of times people say, and surgeons will say, well, we can cure 20% of the patients. I'm yet to see 20% happen in my patients. We can have 20% maybe, or 30%, but long term, but cure is different. I don't see 20% of patients. I don't treat 100 patients and then 5 years later 20% are vacation in Hawaii without any recurrence. I can see those patients for another 5 years, but still they're dealing with their disease. So it's more like disease-free rather than being cancer-free, being cured. And that's the statistic where people play with, well, we can cure 20% of patients. Well, I don't see those 20%. I mean, over the years, I have maybe 2 or 3 or 4 patients who come to me after 5 years who really the disease. But at the same time, I think cutting liver metastasis probably has a biological role. And some surgeons will tell you chemotherapy doesn't give you a complete response. My treatment gives a complete response. So they're removing the tumor from the liver where the chemotherapy can do it. And that's true. Maybe that will help patients live longer. And probably does. But curing means. So patients who come with lymph-positive disease, liver metastasis, as we were saying, those patients do less well than patients who have no CA level. Many years ago, Sloan Kettering formed a paper on prognostic factors and liver resections. People don't follow that, but really there are patients who expect them with liver metastasis to do well, and there are patients who don't do well.
I guess the major important thing that made a difference in colorectal cancer liver metastasis, I have to give this to our colleagues. The response to chemotherapy is amazing. And 10 years from now, any patient with 5 years survival, or maybe 15 years from now, the 5 years survival patient with colorectal cancer liver metastasis was less than 5%. Now the median survival without any surgery, just chemotherapy, is up to 2 years, 24 months. So there is a major difference just like chemotherapy. Now you can define cure, as you said, depending on what you want, 5 years free or not. So we as surgeons like to brag about 5 years, so this is why we go after it, and we say we cure these patients.
I see cure as someone who, that's it, the cancer is not coming back.
Well, as long as you follow them, they're going to develop something in the future. Maybe it's something
okay. I think Professor Gordon will
really not to add much except to reiterate that 2 things. One, for those patients who have what appears to be a complete response, if you do careful intraoperative ultrasound, you can often see the residual area where the tumor was, and you can put a probe in, do an ablation or something like that. But I think the other important thing was mentioned by both professors. That is that doing the chemotherapy up front gives you a chance to see the biologic nature of the tumor. If this patient does not respond to chemotherapy, it's been well shown that these are not suitable candidates for resection, and you end up, in a sense, helping to select your patient population just based on the response to treatment.
There was a nice article in JCO a number of years ago. They say that metastatic cancer lesions is severe radiologically. There is at least 1/3 chance that microscopically it's dead.
And usually you can find it with ultrasound. Not always, but usually you can.
But practically, actually, you're just watching this. That's not probably the way. You're not necessarily looking at those. I think when they start to grow back, they go back to it. And if they go in multiple places, then you know that.
Exactly. It was useless anyway, right.
Okay, at this time I would like to thank you all for coming today, and we'd like just to the dinner is ready, so we'd like to put them to the dinner. Thank you. This is from 1994 until now.
It's close here, so it's not a big deal.
And it's no, this is what we are trying to work with them so that today is the first day of our King Abdulaziz International Oncology Conference.
and the subjects discussed today were according to breast cancer, colon cancer, and head and neck malignancies. Today, at this moment, we are gathering at the Park Haya Hotel, having the workshop about robotic surgery in colorectal cancer, as well as discussing so many issues about screening for colorectal cancer worldwide and in the Kingdom of Saudi Arabia. So I would like to have this as an introduction to introduce Dr. Donald Weaver, Professor Donald Weaver from Wayne State University, Detroit Medical Center. So I'd like to welcome you, Professor Weaver, and I'd like you, if you don't mind, to give me what's your impression about today's conference and what do you think about the outcome of this workshop?
Well, I think first of all, the conference is important because it's emphasizing very common malignancies that are seen not only around the world but also here in the kingdom. Certainly we know, for example, that breast cancer is a very common problem in the kingdom. We also know that in the kingdom it occurs in younger women.
Absolutely.
And this perhaps is something slightly different from what we see in our country, but it emphasizes the importance of screening. It emphasizes the importance of making sure that people are careful and get their mammograms, and that even at a very early age that they're mindful that they can have problems with breast cancer. The other, I think, important thing, the other important disease that we were talking about was rectal cancer and colon cancer. Again, this is a very common disease throughout the world and also in the kingdom as well. And again, is one of those diseases which is quite preventable if a person is mindful of the symptoms that are associated with colon cancer and are willing to undergo the screening that's so important in this disease. I also think that the conference is very valuable because it has a number of different specialists. We have people from medical oncology, we have people from surgery, we have people from radiation therapy. And when you're talking about cancer, it's always important to have all these different specialists working together, because cancer requires, that the successful treatment of cancer requires all of these specialties to be working together. And so when I see a conference that has brought all these specialties together, then that tells me that that's a quality kind of conference.
Absolutely. It's like a multidisciplinary approach.
Which is, of course, essential if you're going to have a good treatment of cancer. It must be multidisciplinary. No single specialty any longer can simply treat cancer. And surgeons, oncologists, radiation therapists need to work together. When they do that, then they have a real chance to make a difference in the care of cancer patients.
Yeah. Well, as you know, today our workshop is going to deal with colorectal cancer as well as some other surgeries and the screening. You know, colorectal cancer is the first most common malignancy in males here, and also the third most common malignancy in females, which is probably not as common like in the Western communities, but it's increasing. The incidence of colorectal cancer in the Kingdom of Saudi Arabia is increasing steadily, and probably because of the changes in the habits of eating especially, and maybe some other genetic and hereditary factors. What do you think that will be discussed, in details, and the outcome of this workshop for tonight?
Well, I hope first and foremost that those physicians who are here and anyone else who is here, or even the public who might be listening or watching this interview, would understand that colon cancer is essentially a preventable disease. If a patient is careful about their symptoms, if they recognize that they may be at risk based on symptoms which they have, they may be at risk based on their family history, they may be at risk based on certain other diseases which are associated with colon and rectal cancer, that they would understand that this is a very important point. And so I hope that in our discussion today, in addition to the technical features about how modern cancer surgery is being done with robotics and with various kinds of special endorectal kinds of procedures, that there is an opportunity for people to familiarize themselves and to recommit themselves to a program of screening that would allow us to detect polyps before they become cancerous, or if we do detect cancers, to detect them at an early age when they're most treatable.
Yeah. Well, by that, I'd like to thank you very much indeed for the excellent information given, and we hope all the success for the workshop tonight.
Thank you, and you and the King Abdulaziz University should be congratulated for the high quality of a program, the excellent speakers, the excellent attendance. It's been a real pleasure on my part and on the part of the rest of the international delegation to be privileged to be here.
We are privileged too. Thank you very much.
Thank you.